this whole issue of end of life, palliative care and care of the dying is incredibly important area. And one of the things I was going to ask kind of for dinner that kind of relates to kind of palliative care in myeloma is where people choose to die, what the motivations for that is, and is it right that, because it's difficult dying at home, it's not easy. I've been through that with family, and it's not easy, and I speak to a lot of family members afterwards that wish they hadn't done it. And again, I don't know that there's enough evidence out there around this whole issue around palliative care and where it should take place. We heard earlier on about potentially hematologists hanging on to patients too long before referring. It's a whole sort of complex area. So in the last sort of 10 minutes, we'll just go from Barry to Rafa, and just in about a minute or two, just shine a torch on this for us. Tell us your perceptions in the role of palliative care, what works, what doesn't work, and just one thing that we need to do that we're not doing.
Well, I don't know if the word palliative is right anymore. In the States, you used supportive care, and I like that idea that, so the supportive care should be there from the very beginning. So I think it's like bring it in earlier. I think the other thing in supportive care doesn't mean somebody specialist like myself or other people in the room. You are palliative care nurses, and the skill is, I think in the majority of cases, what people need as they move towards end of life care in this setting is you've got it. So you only very occasionally would need to refer to somebody like me. And even then, maybe I shouldn't even come in. I should be supporting you to do what you need to do.
So just based on what you said earlier on, Barry, is that palliative care is not around end-of-life care. It's not about care of the dying. In essence, actually, anything that's not curable is the treatment's palliative.
Well,
so the whole thing about myeloma treatment, to an extent, is palliative.
Yeah, well, but palliative is just care and treatment that suits the patient. It comes from cloaking symptoms. So anything you do. So yeah.
I think myeloma care from the beginning to the end should be compassionate and symptoms oriented. And hopefully we can cure myeloma. I mean, I think I'm optimistic. Yesterday I talked about cure because I think we can cure myeloma. But now from the beginning, we should be focusing on symptoms, management, and be compassionate. And we have to be aggressive at the end as much as we're aggressive with high-dose chemotherapy and combination chemotherapy. We have to establish early on what is, patient preference. Talk about end of life. Do you need to be resuscitated? Do you need to be on the, respirator or on a breathing tube? Talk about these things earlier before too late, and try to prepare that in a setting when it's, safe and comfortable. And then toward the end, I think the most important thing is that we don't disappear. The clinician, who really diagnose and treat the patients, to be present at the end. I think it's rewarding to us because we're celebrating their life. We're not mourning the loss because, as you said earlier, their life is, was well lived, respected. There's a lot of things to celebrate about it, and it will also emphasize that we dealing with a human. They're not subjects. They have life. They have history, and will also stimulate us to do better for our patient and to go back to the labs and to go back to the clinics and come up with better treatment. So we need to be present at the end, holding their hands, laughing with them, crying with them, and celebrating their life. I do that all the time.
Hands up who would want Rafat to be your doctor if you had myeloma. Charlotte.
So I agree. I think one of the things that really struck me earlier was there was a question on the iPad that asked how many people routinely discuss end-of-life care as a team after a patient has died. And that's something that we do for every single patient in both the hospital I'm working in at the moment and the one I've previously worked in. And I think that is something that's really important. I think it allows the team to reflect on how these discussions were had. So we're talking about end-of-life care rather than palliative care in this setting. But I think that is it allows you to know what happens. So we have, we try as much as possible to facilitate discharge for patients who would like to die at home, but it is often that we don't find out what happened to those patients afterwards unless we really seek out that information. And so by having these discussions, we can seek out that information, find out what went wrong and what could have been done better. So the next time we want to try and send somebody home, we can try and do it better. Or maybe for that patient it didn't really work out and their family would have preferred them to be in hospital, and we should work to towards facilitating that to be easier for patients who choose that. As well. And so I think that's really interesting. So I'd encourage anyone who doesn't routinely discuss that in their hospital at the moment to raise that and suggest that you do.
Just a minor comment. What I actually learned is the best thing I've done is to go to several of my patients after I discharge them to end-of-life care, because you learn a lot from the setup there, what's going on, how the family dealing with it. And you start thinking about it, how you can counsel the next patient. Because it's an amazing experience. I mean, you never really, it's just, everybody's different. And it's just, sometimes, you do little things that the family don't know how to do. You can say, do this, add a couple drops of things. Don't worry about it. This is okay. I think that's very important. And,
small things can have, it's like the butterfly effect, that the small things for you, just massively transformational for... So, Michaela, just to sort of try and shape it for you a bit more in terms of allogeneic transplantation that results, unfortunately, in... So we're moving on from the question, actually, just talking about more of end-of-life stuff. Is it harder because of the expectation and the hope and the commitment that you need to have for an allogeneic transplantation? Or is it easier because there was always that potential risk of it not working? So what's your perception of sort of end-of-life care of the dying in the context of patients that the allo doesn't work out for them?
I think, not just with myeloma, with all allogeneic, that transplantation gives a hope, and if it doesn't work, there's a up and down. So we're offering you a cure, a possible cure, with all of the percentages and things like that. It makes the emotional roller coaster a lot bigger, I think. When somebody relapses, it feels very tragic in a way, rather than a progressive. This is, in my experience, it becomes a very intense experience.
Sure. Yeah.
Myeloma does tend to be obviously more gradual than some of the other white cell malignancies, but it can be quite tragic.
Yeah, okay. We've got a few minutes left, so it's over to you if you've got any comments or questions around the role of palliative care or... Yeah, thanks, Steph.
It's just about managing the expectations of patients, particularly with myeloma, where you hit, we have a relapse, we have the next treatment. We have a relapse, we have the next treatment. And it's particularly evident in myeloma patients where there's never so much the expectation that there's not going to be another treatment, another combination, even of the same treatments in a slightly different form with yet another novel agent. And managing those expectations, particularly in clinic, and just interesting to hear other people's experiences.
Yeah, no, that's a good point. That relapse and remitting nature of myeloma is I think, difficult for everybody concerned to manage. So what is your perspective on that whole trajectory?
So often I've heard when talking about having one treatment, I've heard it for the use of transplantation, both autologous and allogeneic, and it might buy time. There's so many more novel agents coming along that if you can buy time, you never know what's around the corner. So it's that carrot of hope.
But I think that's not necessarily misplaced. We are optimistic about new treatments that are being developed. We have lots of new drugs that are in development. We have lots of new clinical trials that are coming out. And so I think we're sometimes criticised for maybe offering that approach, which is we hope to have a new treatment that will be available. But I think it's becoming hopefully more and more valid. And with the work that Myeloma UK is doing to kind of increase access to drugs in the UK, we are able to offer more and more treatments to patients. And I acknowledge that there will come a point where for any individual patient that any available treatment may or may not be appropriate, or their disease may have progressed, or they may have other things that prevent them having those treatments. But I don't think it's false to offer the hope of more and more treatments, because I think that's real.
Could I also say, I mean, this is not unique to myeloma. I was at a conference recently, and one of the questions it was a conference for palliative care physicians, and one of the questions I asked them, how many of them were coming across people in the advanced palliative care setting where the patients were still on targeted therapy, and it was quite common. So I think we're going to see, it's new. The world is changing, and the world of cancer is changing. We're going to see this more and more, where there's not this clear-cut line between, let's call it, active treatment and beginning to die. They might have to go hand in hand. I think there's also, we can learn a lot from the children and the children's setting. They never talk about, well, some of my colleagues who work in that area, they don't talk about stopping treatment, they talk about what we can do. So it's very, they don't use the, they don't use the term do not resuscitate, they don't use that. They talk about what we can do. And I think maybe that language is quite a nice one. It's like, yes, this is what we can do for you, this is, so these two, yeah.
Brilliant. We're going to have to stop there. So just a huge, huge thank you to our faculty for your incredible, compassionate, provoking, smart contributions to tonight. It's been really phenomenal. And just for me anyway, as a facilitator, thanks to you guys for your participation.